Well, hello everybody, and welcome to this week's Infection Control Matters. And I'm joined by Brett Mitchell from Australia. Morning, Brett.
Good morning, Martin.
Well, good evening for you, I
Oh,
think.
good evening.
And our special guest today is Professor Hilary Humphries from the Royal College of Surgeons of Ireland. And Brett picked up on a paper extremely quickly, actually, that appeared in press in the Journal of Healthcare Infection, or Journal of Hospital Infection, should I say. And Hilary thought he'd actually possibly had too much time on his hands by picking up on it quite quickly. But anyway, what's the paper, Brett, that we're going to have a chat about? And
Yes, look, I got an alert from email alert, and it popped up, and I thought, this is something different. Let's see if we can have a chat with Hilary about it. So the paper's called Workload for Infection Prevention and Control Teams in Preventing Nosocomial Tuberculosis. It's currently a pre-proof with the Journal of Hospital Infection, so it's accepted and been peer reviewed. So Hilary, thanks so much for joining us to chat about this paper.
You're very welcome, and I have to say I didn't think it would hit the headlines so quickly. So I'm very flattered and very impressed. You're so much on top of the literature.
Look, we do like things that just spark a bit of interest, and that's obviously our interest from time to time. But there's things out there. There's so much that's written, and it's often the same sorts of things. And I just thought this is a bit different because there's been a lot of discussion in recent times about workloads in healthcare, generally, and then in the infection control space, it's been a couple of difficult years. But prior to COVID, even before that, we weren't really great at articulating and describing what we did and some of the important considerations about workload. So that's, I guess, where I thought this paper might be a bit of interest to share with listeners. So, Hilary, just want to take us back a step and talk to us about where the setting for this particular paper, and then perhaps a little bit of background to why you did it.
Sure. So first of all, I'd like to acknowledge the team, and particularly Caoimhe Murphy, who's the first author, who did a lot of the work, as well as infection prevention control nurses Fionnuala Duffy and Fiona McCormick, as well as microbiologist Sinead O'Donnell and Fidelma Fitzpatrick. And it really was something we were thinking about for a couple of years as to how much time we spend at this. And an opportunity arose because Caoimhe, who's a medical student, had an opportunity over the summer to do a summer student project. And it may have been a special study module, but in any event, it was an opportunity to analyze the data we had, as well as do a little bit of prospective work. And it really arose because we had started to do this a number of years back because we were concerned we might miss cases that might go on to be nosocomial tuberculosis. So it was really a kind of a patient safety issue. And it was particularly important in our hospital where we don't have enough single rooms. We only have about 16% single rooms, and we only have 12 air-controlled ventilation rooms. So our facilities for managing, patients with infectious tuberculosis are limited. So that's kind of where it came. And it really was looking, as you say, in the context of pre-COVID of, MRSA, CPE, C. diff, norovirus, etc. So that's kind of the background to it. I can tell you a bit more about the hospital if you want, but that may be sufficient.
Yeah, I think so. Just for our readers, listeners, that might be useful. But the Martin's having a giggle. Yes, I got the stumbles between listeners and readers tonight. But Hilary, just on the 12 rooms that you mentioned that might be suitable from a ventilation point of view, are you talking negative pressure rooms with an anti-room?
They're basically these kind of neutral pressure rooms which facilitate either source or protective isolation, but they're also scattered around the hospital. So there's 2 in the critical care area, and then they're all, they're used for patients with, that are immunosuppressed. So we're really under pressure as to how we allocate those patients and where they are. So
yeah, and that'd be a trick too with staff, wouldn't it? Because staff getting used to the procedures of dialing. I know that's changed a lot in the last couple of years, but prior to that, when they're scattered throughout the hospital, and trying to presumably match up those TB as a priority against all the other priorities for single rooms, and then the expertise that might be in those wards. Because would you have TB patients in all kinds of wards, or
we might, and we might also have immunosuppressed patients in those areas as well. So you're kind of, it's really difficult, for nursing and other staff. And indeed, even though they're in, contained rooms and they're protected within the rooms, the idea that you've got, very vulnerable patients in the same geographical area, but you also have patients who are at high risk to those patients, even if it's an air controlled room, it's kind of difficult sometimes for people to grasp. and understandably so. And ideally, you'd have the rooms either in a designated area, or you'd have sufficient of them separate away from, say, patients with hemato-oncology.
I mean, how does it work then? Presumably the room is switchable then from one positive to negative, and
well, it's the neutral pressure.
Oh, okay.
It's the neutral pressure system. So basically, that means you're basically protecting the patient from what's outside, but you're also protecting the outside from what's in the patient, because you've got the positive pressure lobby, and you've also got the extract usually in the ensuite. Yeah. So it's the kind of
if you can switch it, that there's a recipe for disaster there.
Correct. So. And we've actually looked. One of my colleagues, Tony, we looked at some parameters on these rooms as to whether they do what they say they do, and they do it. But again, it's like every technology; it has to be used correctly, and of course, monitored and appropriately maintained.
Okay, so now tell us about this study then. We got the background nicely.
So it consisted of, a retrospective 4 years and a prospective 2 years to look at, basically how much time at our weekly infection prevention control meetings we spend on this. And so we meet every week for approximately an hour, and there might be, I think, roughly about 10 people there. And that what we found was that the most difficult patients were actually the ones that were suspected of tuberculosis, the ones that were kind of, fairly obvious and diagnosed. They went into a single room, into a air-controlled isolation pretty quickly, and the discussion was over fairly quickly within a couple of weeks, maybe 2 weeks, whereas, those patients we weren't sure about, the discussion might go on for a lot longer. We were waiting for test results. We were liaising with the clinicians, was it tuberculosis, or maybe was it some other condition like sarcoid or something like that? And, this, and it, I think, took up something like about 19% or about 20% of the total duration of the infection prevention control meeting. So a significant amount of time, bearing in mind those meetings are also discussing outbreaks and routine issues like CPE surveillance, etc. Yeah,
that certainly adds up, doesn't it? You think with that many bodies each week talking about that number of cases in that amount of time.
Yeah, because I've never really factored that in. It's just something you do. But actually, to say over a period of time, it is taking up this amount of time, you're almost saying, well, actually, we've got to build that into the program and actually allow for that, because while we're doing 20% of our time in that meeting, we're not talking about surveillance or other aspects as well.
And then just one other fact, if you're interested, is that for about 17% of the cases, there were some infection prevention control issues. Those might be minor, but it might also include delayed recognition that the patient might have tuberculosis, and therefore there's a potential risk to other patients and staff with potential contact tracing, or at least checking patient susceptibility or patient vulnerability. And we also looked at sorry Brett for cutting, but we also looked at number of specimens, and there were issues about turnaround times. We needed quicker times, more for culture. So we had microscopy and PCR, which should give you same day results. But sometimes we were waiting for the culture results, and that meant we had to keep patients in those rooms until we had excluded tuberculosis.
Yeah, I think I saw. Might have that figure wrong off the top of my head, but the sort of in-house testing for TB took about 23 days on average.
Correct. Yeah.
And so.
Well, it took up to 23 days. So obviously, sometimes it. Yeah.
Okay. And so you made a good point there. I mean, you sort of prospectively collected that time element of each week, but there's the contacting tracing element for those cases that slip through the net initially, and then the just general chasing up of results, plus or presumably education and additional support that goes in for anyone who might be in isolation. So did you capture that prospectively, or just sort of just as part of the norm?
No, we weren't able to do the contact tracing. We just didn't have sort of the details on it. And obviously there would be, as you said, it'd be also a lot of informal education and so on. I mean, I think two things sort of came out of it. Number one is the requirement for ongoing education. Obviously respiratory wards will be aware of possible tuberculosis, but a patient could come in to a surgical ward maybe with a cough, and nobody kind of thinks that it could be tuberculosis, and then you might have that patient on an open ward for 2 or 3 days. So I think that's an issue. And then I think particularly in emergency department, where again with overcrowded emergency departments it can be challenging. And then as you said, the laboratory testing, which I think we kind of probably need to fine tune. And I think the other thing, looking at it, is, maybe more streamlined system for collecting the data to reduce the time and maybe to have the data analyzable as well. So, that was part of what this exercise was about. It started out as an audit to see, well, what are we doing? How does it work out? How much time do we spend? Can we cut down the amount of time we spend? And I'd be very interested. I don't know whether it might or might not provoke others to describe their experiences, but, there's probably others with similar or maybe better experiences who actually do this much better,
Yeah, and presumably during the period this has included COVID, maybe you haven't had quite as many cases coming in, or is actually that not
correct?
changed at all?
Yeah. Yeah, 2020, I think the numbers were significantly down. For example, patients admitted with confirmed TB or suspected or confirmed TB were 31 in 2020, whereas it was 61 in 2018. So the numbers came down definitely, yeah. And also the number of mean isolation rooms, the mean isolation time, in other words, the mean time in the isolation room obviously didn't change.
Oh. Yeah. Now, nothing to do with your paper, but speculation on why those numbers of TB patients decreased, just because of some of the public health measures that were put in place, perhaps? Or do you think there was just a lack of utilization because of other increased demands?
Or masking?
Yeah.
Possibly that, or maybe, who knows, there may have been cases missed in the community or in the emergency department because patients didn't come in, or people's minds were on other things, I'd say there's lots of reasons,
Yeah, a lot of other competing priorities, because those numbers seem quite stable for a few years. So something obviously changed that's affected that. So so I think, you make the point well in the paper about early identification, and patients potentially, if they're being susceptible to be identified earlier, would save a bit of time. And you touched on the sort of testing components. What about single room provision? I think it was about 16% of your hospital had single rooms, and so a small number of those being these sorts of rooms that you can use for pulmonary tuberculosis. Are there any plans in your hospital or thoughts that this needs to be increased?
Well, there have been plans for a suite of isolation rooms, but like a lot of these things seem to take longer than they should. I mean, the hospital was opened in the 1980s, but it's a 1970s design with a combination of 6-bay rooms, double rooms, and single rooms, with a ward kind of outline of about 35 patients. And so you maybe 4 or 5 single rooms out of that whole number. And even if you allow for other reasons for isolation, and never mind maybe issues of compassion, so somebody end of life care, you've clearly not got enough. Never mind the fact that not all of those rooms are en suite rooms. So not enough isolation rooms, not a number of the correct types of isolation rooms, and not enough air-controlled isolation rooms would be the message. As well as, obviously, I would say the other thing is space between patients, and I think this is true of other hospitals. We traditionally built hospitals where we had the beds too close to each other, even in areas where you don't have sort of Nightingale wards. And I think what COVID is telling us, that we really have to have more space. We need to have social distancing in our hospitals for our patients,
or better
ventilation and better ventilation.
And better ventilation, well. I think so. Yeah.
I mean, Hilary, then you're looking potentially to be able to save time, because you've 60 odd cases, and yet it's taking a fifth of or a quarter to a fifth of the time of the meeting. And quite a few of them are not confirmed, or that they actually are suspected only and don't go on. So how do you think you could save the time then? What measures could you bring in?
Well, I think, first of all, earlier diagnosis and suspicion, and having both the team, but also the people admitting patients, the people on wards, thinking about TB earlier, rather than later, when then all the knock-on consequences are the case. I think we can probably improve the laboratory diagnostic testing, which has clearly been under pressure from COVID and other reasons. I also think probably our liaison. So one of the things we do is, if, for example, the patient comes in and there's a question about TB, and usually we kind of exclude TB if we've 3 negative, say, sputum, and they're negative on on microscopy or PCR, and it doesn't sound like TB. Now, if there's obviously, if we still, TB is possible, we wait for the culture. But sometimes the other thing we do is, we talk to the consultant or team involved, and if they say, well, look, we've moved on from thinking it's TB, and we now think it's probably, a pulmonary tumor, and TB is way down the list of priorities, and maybe that process could be quicker. So those are some of the possible areas, and then, as I said, a kind of maybe a pro forma, a more a more rigorous pro forma that's easier to fill out and quicker to fill out and reminds us to ask the questions that we should. I think all of those things would probably help.
I mean, I suppose if people are outliers and they're not in an area of respiratory medicine, then they're more likely to think of other things first, try and rule those out, and then come to TB rather than the other way around. So, it's an issue, isn't it, when people are not in specialties, because medicine is so specialised these days. It's not general medicine, general surgery. You could be on endocrinology, couldn't you? And maybe people aren't picking up on it. So that's a challenge.
And I think the other thing is that, the view out there, even amongst healthcare professionals, is probably the TB is declining. And it is in global terms. Obviously, we see still significant TB in the population that has come to Ireland in the last 20 years, as is the case in the UK and elsewhere. But its impact is still very significant in terms of the risk of nosocomial spread, or indeed occupational spread as well, which is a concern. Particularly now, as we, like other countries, have moved away from routine BCG vaccination.
Okay. Thanks. Thanks very much for having this chat with us, Hilary. I think these type of papers is really important to shed the light on what teams do and to provide that sort of learning experience. So there'll be things that you've identified here, and as you said, there might be others who want to write up their work in this space to be able to learn from each other. And I think it's also really important because we need these kind of data to be able to quantify down the track, whether we're doing business cases or various other pieces of work in research, to have some decent data on time that some of these things undertake. Because without that kind of data, we can't inform some of those business cases and we can't do proper cost effectiveness analysis. So I'm sure your paper will be used in the future for those types of purposes. So thanks very much for coming on and sharing with us today.
You're very welcome. And thank you for asking me.
And thanks to all our listeners who've joined us for this podcast. Until next time, it's bye from me.
Bye from me.
Bye.